On va commencer. Let's start. We are beginning the second session, the plenary session of this day. It's a tradition in these events of the AFRC to invite each year foreign researchers to speak about their work and their approach of our domain within their specific fields. So today we will have the pleasure to meet Anne-Kathrin FETT from the Institute of Psychiatry now in London, and just after her there will be Philippe Azouvi, a French researcher who works with us in our lab now. So I will present them separately. For Philippe, it will be just later. There will be 2 25-minute sessions with short questions. We will translate them for, if you want, for Anne-Kathrin. Anne-Kathrin is a psychologist. Despite her very young age, she has done very impressive work in different domains, and some of her work are now among the classical papers that we use to have our own rationale for our studies. So I think she will describe a little some of these papers. These papers deal with outcome and social cognition and quality of life, but she also has done, beside epidemiologic studies, she has done also neuroimaging, trust games, so something like neuroeconomics, and very, very wide area of research and method. So thank you, Anne-Kathrin, for sharing with us some of your research. Thanks.
Thank you very much for the kind introduction. Bonjour, Madame et Monsieur. This is unfortunately all the French I can speak. So, is it okay? Can everyone hear me? Yeah. All right, can everyone hear me now? No? No? Yes, better? Yes. Okay, I just have to speak up a little bit. I'm very excited that I can share my research findings on cognition, functioning and quality of life in schizophrenia with you here. And as you know, schizophrenia is a very deliberating disorder, and it's been rated the third most disabling psychiatric disorder in the world. It's very chronic, and due to its long-term impact on patients, it leads to high economic costs. Because patients need very intensive medical care. They need socio-economic support. Okay. And there's a loss of productivity in workforce. In addition, schizophrenia is also associated with very much personal suffering. And this is, for example, reflected in high suicide rates in the disorder, and also in a lower life expectancy and lower quality of life. Traditionally, in schizophrenia, symptoms have been the definition of outcome. And that's why most treatments focused on improving positive symptoms. But there is, while approximately 50% of patients experience symptom remission, a lot of them don't experience remission in functional outcomes. So exactly between 75 and 85% of the people remain to have problems in everyday functioning. So this finding led a bit to a shift in the field from focusing on symptoms as a treatment target to focusing on daily life functioning as an important outcome and treatment target. So the key question is really, what, if not symptoms, is predicting functional outcome? And cognition is one of the key suspects because it's reliably impaired in the disorder. It's in most patients that you find the impairment. It's in the early stages of the illness, but also in the late and chronic stages. And it's not just influenced or secondary to symptoms. So the renewed interest in cognition is reflected in the formation of the matrix. And the matrix are luckily not these guys, as you may think, but they are the Initiative for Measurement and Treatment Research to Improve Cognition in Schizophrenia. And this committee has the goal to develop reliable and valid tests and to assess how they can be used as standardized instruments in trial evaluation. The matrix did a big meta-analysis to find out what cognitive factors are impaired in schizophrenia. And this is a list of factors that have been identified. So it's processing speed, attention, working memory, verbal and visual memory and learning, verbal comprehension and reasoning and problem solving. And more recently, the matrix also added social cognition as another factor to this list. And as you heard before, social cognition is very multidimensional, so I don't think I need to say a lot about it because you're the expert in it. And the linkage between cognition and outcome is really the most important rationale for treatment of cognition. So it's not just important for pharma companies who at the moment are really heavily looking into developing medication, but also for cognitive remediation, of course. Just briefly to recap, neurocognition and social cognition are associated, but they are by no means overlapping. And this has been shown statistically, but also there are double dissociations in real life, for example, in high-functioning autism, where you have good neurocognitive functioning often and impaired social cognition, whereas, for example, in Williams syndrome, you have the opposite with good social cognitive functioning and not so good neurocognitive functioning. So before I come to presenting my work under the associations between cognition and outcome, I want to tell you a little bit more about what outcome is. Outcome can be defined in terms of community functioning, and that is, for example, whether someone has a job, how many hours the person is working, whether they're able to live independently, whether they can cook their own food, whether they manage to do their own shopping, whether they can take care of their physical hygiene. And it's also daily activities such as hobbies or seeing friends and family relationships. So this is really how someone is doing in the real world. Then we have outcome measures that assess social behavior in the surrounding, and it's often outcome measures that are assessed by nurses or staff on the ward, seeing how someone is doing in a structured environment. We have outcome measures that are lab-based, which are called social skills and problem-solving measures. And these are, for example, role plays, where you look whether someone improved in how they solve a conflict or other social problems. And these measures are really mostly an index of skills and capacity of how someone could do in the real world under ideal circumstances. And you can imagine that the functions in the social skills and problem-solving domain, if you use that as outcome, it's a lot closer to cognition, because you have both assessment and structured environments. And with respect to community functioning, you also have to deal with a lot of uncontrollable factors, such as, for example, local unemployment rates, the factor whether social support is available. Maybe for someone living in a city, it's a lot easier to get support than for someone living in the countryside. So if you look at outcome and at treatment effects, it may be that the sensitivity to change is much higher in the measures that are lab-based. The Matrix Committee, and in particular Michael Green, did a lot of work on cognition and functioning. And he looked at neurocognition and found that card sorting, memory, and vigilance explained a substantial amount in outcome. Also, he did research showing that these associations are not just cross-sectionally, but also longitudinally. So cognition at baseline is a good predictor of outcome at least 6 months later. Until recently, there was a little overview work on social cognition, but Shannon Couture did a review showing narratively that social cognition is associated with outcome as well. Based on this work, there were 2 remaining questions. Namely, what is the additional value of social cognition when you look at outcomes? Can it improve functioning even more when neurocognition is being treated? And the other question is, are there specific associations between specific cognitive factors and particular domains of outcome? And this is what my work was about. So with my colleagues in Maastricht, I did a big meta-analysis looking at the association between social cognition and neurocognition and functional outcomes. And in terms of outcome, we looked at community functioning, so the real-world outcome, at social behavior in the milieu, at social problem solving, and social skills. With respect to neurocognition, we included all studies that use the matrix cognitive factors or reported an overall cognitive factor. And with respect to social cognition, we included studies looking at theory of mind, emotion, perception, and processing, or social perception and knowledge. We did a literature search, and we retrieved 52 studies that investigated exactly these associations. So that led to a final sample of 2,692 individuals in the study. And here you can see the results. It's a bit complicated, but I try to guide you through it. So, so on the left-hand side, you see the mean correlation, the effect size, and in terms of correlations, an effect size of around 0.5 can be considered large. 0.3 is a medium effect, and a small effect would be around 0.1. On the left-hand side, you can see the results with respect to the neurocognitive factors, and on the right-hand side, the results with respect to social cognition. And what we found was a reliable, broad pattern of neurocognitive deficits that were associated with worse functional outcomes. And you can see that overall, social cognition was a bit more strongly associated with outcomes. When we did a comparison of all these factors, what we found was that specifically theory of mind, and that's why I marked it in red, was more strongly associated with community functioning than any of the other factors except verbal fluency. So this study suggests that neurocognition is important, but social cognition has something to contribute, and particularly theory of mind might be of interest. And for me, it was intuitively appealing, because when I think about functioning, for example, in a work environment, it's often more about how you are with people rather than maybe how clever you are. So for me, this kind of made intuitive sense. In this study, we couldn't really look at how non-social cognition and social cognition interact with outcome, but there's work from a colleague called Stephanie Schmidt, and she looked at the associations, and what she found was that the pattern in how cognition is associated with outcome is most likely to look like this. So neurocognition influences social cognition, but has an independent impact on outcome as well. when we think about the processes that stand behind these correlations, we are still looking a bit at a black box. There's very little known about the intervening steps. But what you could imagine is, for example, that a better cognition is associated with better learning ability. People can adapt better to their surroundings. Maybe they understand others better. They behave appropriately in social situations. And maybe they have just the better skills to organize support networks and are reliable and structured. But I think there's a lot more research needed here at the mechanisms that stand between the cognitive factor and the outcome. So in conclusion, I can safely say that social and neurocognition are important factors when it comes to outcome, and I think we will see in future that they become a more and more important treatment goal. I haven't spoken about the social skills, social problem solving and social behavior yet, and this was because there was very little data on it to date. So in our meta-analysis, we couldn't compare neurocognitive functioning to social cognitive functioning with respect to these factors. I just listed the findings here very briefly. So we saw that executive functioning or reasoning and problem solving, visual and verbal learning and memory were reliable, associated with all outcomes. And in addition, social behavior in the milieu was specifically associated with emotion perception, and social problem solving and social skills were specifically associated with attention, and social skills were also associated with verbal comprehension and social perception. And other correlations were ranging between 0.18 to 0.39, so small to medium effects, but the effects were overlapping, so there was no one cognitive factor that stood out between all the others. So I told you a lot about functional outcome now. And now I want to tell you a little bit about quality of life, because it's quite different. Quality of life is defined by the World Health Organization as a state of complete physical, mental, and social well-being, not merely in the absence of disease. And it has several aspects, such as satisfaction with your surrounding environment, for example, transport, self-esteem, family relationships, or relationships with friends, your physical well-being, psychological well-being, and autonomy. So it's really very multidimensional as well. And when you look at questions for functional outcome and quality of life, the difference is that when you look for functional outcome, you ask, how much time do you spend with friend XY? Whereas when it's about quality of life, you ask, how do you feel about the amount of time that you spend with this person? So for one person, 2 hours in social contact may be absolutely fine to be happy, and for another person, they may think they should have 7 hours. So it's really the subjective reaction to objective conditions. This is another slightly complicated graph, and it contrasts the subjective quality of life and cognitive performance against the objective quality of life and cognitive performance. And in the dark gray bars, you can see the objective quality of life, and in the light gray bars, the subjective quality of life. And the positive effects show you that better cognitive performance is associated with better quality of life. So you can see that almost all cognitive factors are reliably and significantly associated with objective quality of life. When you look at the subjective quality of life, you see negative relationships mostly. So this means that a better cognitive performance is associated with a worse quality of life. And I have to say it's not significant, but basically what it boils down to is that better cognitive performance is associated with higher objective quality of life, and there's no association between cognitive performance and subjective quality of life. And these findings are based on a meta-analysis of 20 studies, so it's quite a big sample, and it's quite interesting. And the authors explain their findings in terms of insight. They say if you have better cognitive performance, your insight is better. And if you're very ill and you have full awareness of your illness, that decreases your quality of life. There's very, very little research with respect to social cognition and quality of life. And I did a study together with a colleague in Holland, which was a group study, the genetic risk and outcome and psychosis study, a multi-center study with more than 1,000 patients. And we assessed theory of mind with the hinting task, emotion perception, and we assessed IQ and used a composite score in the study. And we assessed quality of life with the WHO quality of life graph. And just to give you an idea of the questions that people have to answer, it's, for example, how satisfied are you with your personal relationships? How satisfied are you with your sex life? How satisfied are you with the conditions of your living place? So it's just really about how happy a person is with the current life circumstances. Our results showed, as the previous slide that I showed you, that IQ does not predict quality of life. Theory of mind was negatively associated with quality of life, and we found an interaction showing that for particularly people with very low symptom levels, there was no association between theory of mind and quality of life, whereas for people with high symptom levels, and I should say general symptom levels, so high depression and anxiety, etc., there was an association with quality of life, and they had a lower quality of life. So again, these findings may probably best be explained in terms of insight into the illness, and maybe negative social comparison that patients engage in. There has been a recent study also by the group here, and correct me if I'm wrong, but I think they also found no association between cognition and quality of life, but they couldn't replicate the interaction between theory of mind and symptoms. And there's very little work, so I think we need to wait a bit for more studies replicating these findings to show whether it is actually a true fact. There's been one recent study published, and they looked at the clinical determinants of life satisfaction in chronic schizophrenia in a large sample of more than 1,000 people. And again, you can see here at the bottom in the red box that both neurocognition and social cognition are hardly associated with quality of life. Very tiny effect sizes, correlations of 0.05. And you can see in the top red box that actually the general PANSS score is probably the best predictor. So the authors say particularly watch out for depression and anxiety in patients when it's about quality of life. Overall, all these factors you can see in the table explain 20% of the outcome and quality of life. So this shows you that there must be a lot of other factors that are important with respect to quality of life. So my conclusion that I wanted to send you home with is that with respect to quality of life, social and neurocognition are not so important. So that brings me to my conclusions. I think when we're looking at cognition and outcome, we need to be very careful to think about what we measure. So is it self-report? Is the instrument rated by nursing staff or by psychiatrists? Are we looking at quality of life, which is more subjective satisfaction with the life, or are we looking at functioning? It's also important to look at what kind of measure you use. For example, some outcome measures look at health-related variables and explicitly ask people, do you feel depressed? And if you use something as an outcome measure, asking people, do you feel depressed? And you also use a depression scale to predict it. It's no surprise you find a very high association. So it really depends what you're looking at. Another point which I haven't mentioned at all is that it's also depending on the quality of the cognitive measure. And the quality of the neurocognitive measures is quite good, but there's still a lot to do with respect to the social cognitive measures, and the Matrix Committee is currently working hard at validation and standardization of social cognitive measures. So with respect to objective outcomes, social cognition and neurocognition are important. And initial treatment studies also show that combining both and remediation yields best results. With respect to quality of life, I think it's important to have a look out for people who have good insight and maybe see whether they need additional support or coping help, and to watch out for the general symptoms like anxiety and depression. And finally, I think in future what we will see with respect to outcome measuring is an increase of the usage of diary apps where you can link subjective states across the day, for example, by asking patients how they feel a couple of times per day, to linking that to the objective environment. So I think that will be a good way in future to assess the link between the subjective and the objective states. And also to be able to tailor to individual patient needs. So, last conclusion, I think when you do cognitive remediation, you have a good chance to improve functioning. And this may later translate into improved quality of life. But if your cognitive intervention doesn't improve quality of life right away, don't be disappointed. I think it's important, nevertheless, to assess both to have an idea what the patient subjectively is thinking. And finally, my last conclusion, when we look at the big meta-analysis looking at cognition and outcome, it becomes clear that social and neurocognition explain about a quarter of the variance in outcome. So it's a very substantial amount, but I think it's very important to keep an eye on other factors that may mediate this outcome, such as insight, motivation, the availability of social support, and symptoms, of course. I would like to thank you for your sustained attention, and I would like to briefly acknowledge the team. So we have Jim von Oz with the monkey on the head. Next to him is Lydia Krabendam. Below Jim, it's David Penn. I believe most of you have seen him maybe last year here. Then we have our statistician, Wolfgang Fichtbauer, in the middle, and left at the bottom is Mari Dominguez, and then we have Araya Mat, who did the quality of life study. Thank you very much.
Thanks a lot for this very impressive talk and all this data. I have one question to begin, but let's start thinking about your own question and tell me if you want to comment on this work. My question will be, I would like to take the perspective of clinicians and the correlation that you have between functioning and neurocognition, it grounds our will to remediate cognition. It's our motivation. But I understand that patients don't have the feeling to be suffering about this kind of cognition, of bad cognition, because they don't say that they lack of friends, they lack of... And you show that by with the absence of correlation between these cognitive impairments and quality of life. So it appears that we are in a situation where the patient don't have the basic motivation of changing something which does not make them suffer. So how can we solve this problem when we meet a patient and ask them, you don't have so many friends, we would like to improve that, but the patient has revised his what he wants, so he doesn't want. So, can you comment on this problem for us?
Thank you very much. Yeah, that's an important question, and I think it's a question that you face in all fields. What do you do if a patient is not motivated for treatment? There's often little you can do. You can't drag them into the clinic or in the program and force them, but I think good approaches are psychoeducation, explaining the problem, showing or engaging patients into motivational trainings to increase that. And maybe also when patients are admitted, take the chance to, when they're admitted in a hospital, take the chance to really have a lot of programs that tackle this, so that when they're back in the community, you can still go on, and maybe you have increased the motivation. And I think with respect to cognition and quality of life, it's maybe a bit the way that when someone has really, really bad cognition, that the insight lacks, but that people in the transition phase will be possible to motivate them for the training. So this is where you need to get them, and I think the psychoeducation and motivational interviewing is approach to that.
You? There are some comments or questions?
Thank you for your talk. How do you measure objective quality of life? How do you measure?
Oh yeah, well, I use this microphone here. Objective quality of life. Yeah, I should have maybe explained that a little bit more. So objective quality of life is basically another fancy word for functional outcome. So you basically have structured interviews, and clinicians or psychiatrists rate how a patient is doing in terms of also for example, social relationships or having a job. So it's very close, and I think it's a bit confusing that there are these two terms around basically describing the same thing.
Other question? Maybe I yes.
Sorry. Mm-hmm. Yeah, sorry, did I understand the question correctly? You want to know whether we are actually busy with developing something. I think at the moment it's a very big trend, at least from what I picked up in London at the Institute of Psychiatry, that apps are developed for mobile phones which can monitor subjective quality of life, and also apps are developed that allow for interactive feedback from the therapist, so where actually messages can be exchanged. And I myself am actually just starting a research project looking into social relationships of patients with schizophrenia in daily life using a little app on the iPod. So there's work on the way.
Okay. Other question? I have a last one, so I would like to ask you. I'm coming back to the complex interaction between cognition, symptoms, and quality of life. It's a negative interaction. Is it a ground for you? Is it conceivable that sometimes improving cognition in patients with high symptoms can be counterproductive and decrease their quality of life? And is it a ground to investigate the side effect of remediation? Because I'm not aware that there are a lot of literature on the negative and the danger with this kind of practice.
I think that's a good point. I personally wouldn't think that you increase insight that much, that you decrease quality of life. But I don't think anyone ever has really looked into it. So it's something that you may want to investigate when you offer a treatment. And that's what I also meant by it's a good idea to monitor the objective and the subjective quality of life before and after treatment to see what's really changing, and to offer coping skills programs to patients that have an increased insight. So I think there needs to be more research, and people should get the offer to receive programs that help them cope with maybe their new insights about their illness.
Thank you very much for this work. And now we are coming back in France, français.